I'd like to invite the panel to come on up now. Dr. Agarwal, Dr. Marvin Eng, Dr. Jaffer, Dr. Patel, Dr. Shah, and Dr. Singh will join us a little bit later. We will be going out to see Dr. Rizik as the operator. He's got some guest operators, Dr. Ali, and of course the ever-present Dr. James Hermiller. Guys, can you hear us all right? Dave, you're nodding. You're all good?
Yep.
I think you know the panel members already, so you, without any further introduction, let us know about what you're going to do.
Hey there. Hi there, guys. Good to have you. David Rizik, Jim Hermiller. Jim and I have been doing cases for many years. We think we have our thing down. We think we have our communication down. And then Dr. Ziad Ali walks in the room and we realize we don't know a thing. I must say, Ziad, we are learning so much, aren't we?
Oh, man. Old dogs can learn something.
I'm telling you. We are learning. We're just trying to get them a little more confidence, you know, let them come out of that shell a little bit. All right, we have a great case. In the room, let me set the room up. We have Maddie, who's a terrific nurse scrub. We have Aaron, who does a spectacular job on x-ray. We have John. We have Dr. David Coronary, anesthesia. One thing about live cases that I love to do is get cardiac anesthesia. We're not using general anesthesia or anything, but it's one less thing that we have to worry about. And we have another professional, talented set of eyes on the patient. So we're doing the same type of conscious sedation, but he's doing ACTs, he's doing conscious sedation. It really lets us just focus right here. And it's a habit I've gotten into and I really like it. We have a lot of support from Shockwave, from Boston Scientific. I think it's going to be a great case. Have I forgotten anyone? I don't think so. Oh, and my favorite part, can we put the camera right here? Herms, why don't you comment a little bit on the Protego system?
Yeah, this is where we all need to be. We need to have some system that protects us from the radiation and gets us out of the lead. And the second part of this equation, which we talked about yesterday, it's not just the doctors. We don't get as much as the staff do. And it's for the staff as well. And so, you know, I think this sort of system takes care of that whole group.
All right, what's our fluoro time so far? 20 minutes of fluoro, and what's my radiation exposure?
You have 2 zeros and a 0.2.
So of the three of us, 2 zeros and a 0.2. Just think of the radiation we would be getting. And the head is protected. We use barrier methods, nothing up here, nothing on the arms. Now the face, the head is protected, the arms are protected. Protego, we need to be moving in this direction. Please, if you talk to the Protego reps back there, talk to Jim Goldstein, who knows a lot about this. We really, really, really need to go to a zero radiation, zero lead on our back. Okay, go to the, great. 86-year-old female, multivessel coronary disease, had rotational atherectomy of the right, a ridiculously calcified right when we did it, or when the treating physician did it. The LAD was a no cross. So we decided, Herms and I decided, we're going to take on 2 no crosses. And the patient has, obviously, risk factors for coronary disease. Next slide. Here's the LAD. Herms, you want to describe what we're seeing?
Yeah, very heavily calcified. You can see that subtotal proximal stenosis. And then it's just heavily calcified all the way down. Really, there's a kind of second modest-sized diagonal. And then sort of in the mid to distal, where it's not calcified, there's also a significant lesion.
Next picture. And go to the next picture, because that's a better one. This is the straight AP crane. And kind of much the same, but that mid is really, really tight. Yeah. And difficult to get stuff across.
Yeah, and that proximal. That proximal was
so, of course, difficult. Herms, this was a no cross going into today. Go to fluoro. So, of course, Herms got through with a, okay, there we go. Go off, Herms, a minute. Go to the images we took. Of course, Herms got through with a workhorse wire. We started off with a 1.5 balloon. Go next.
I had to jackhammer that a bit.
Yeah, you did. And we have a Guidezilla. We have the Boston Scientific Guide Extension. Love it. It's a really user-friendly guide extension. Went from a 1.5 to a 2.0 to a 2.0 NC just to prep this so that we could do imaging. Ziad, you were very encouraging about doing some lesion prep so that we get a good quality OCT.
Absolutely.
So, guys, if I could ask a question before we get on to
Oh,
that?
absolutely.
That's the 2.0.
Everybody here is looking at this and saying, well, you did a rotoblader on the right. I mean, usually when you do a rotoblader on one vessel, you got a better than even chance of needing it on another vessel.
Patience,
There's
my
a
friend.
lot of calcium up there.
Patience.
Any reason why we didn't go to atherectomy? You just felt that you could do this with a balloon?
Patience.
Patience.
Ziad, why don't you explain when we huddled before this case, what our diagnostic and therapeutic algorithm was going to be in terms of roto, shock, balloon. Why don't you go
Sure.
through that?
So the original algorithm or thought was that since we got a 1.5 balloon across this relatively quickly, that we take a guide extender, and if we could get an NC balloon and make enough space for the shock wave, we would just shock wave this. That didn't happen. We had difficulty crossing even after some predilation, and then the next step led to rotablation. That's
Okay,
where
so
we are.
I wasn't crazy after all.
No, you were right on.
John is always right on.
Yeah.
Okay. Any other comments from the panel? We're eager to hear what your thoughts are and how you might have done this differently.
Anybody on the panel? We've got a few other, how would you hand it in your lab?
Yeah, I'm actually interested, is that a 1.5 burr, and how do you choose your burr size?
I always start off with a 1.5 burr, and rarely, this is just the David Rizik way of doing it. I don't say it's the right way. I always start off with a 1.5 burr, and it's not often that I have to upsize. In the old days, you get 1.5, 1.75,
Yeah.
but not anymore.
Right. In the old days, you'd think, well, maybe should I go 1.75? Now, in the day of shockwave, this is basically, if we get into an undilatable situation after this, we'll use shockwave and it'll work.
So, anybody else?
Anybody use a 1.25 on this one? Show of hands on the panel. Everybody's afraid of the entrapment with the 1.25.
Yeah, we thought maybe we could do a live entrapment for you, but we decided not to.
Yeah. We're going to show you how to get out of a live entrapment. Okay, so we rotoed next. And then why don't we show the OCT?
Yeah.
Because after we rotoed, the OCT, we couldn't get a 1-2 balloon down initially, and then after the roto, the OCT flew down. So why don't you go to it, Ziad?
Great. So here what we're going to do is co-register for you live. This is the angiogram. Co-registration looks at the area of interest by looking for contrast. I'm just drawing a line from the distal vessel up towards the proximal vessel. And what should happen is the OCT should identify this dark marker, which is the lens, and then we'll be able to look at the artery from the inside out as well as the outside in. This is our vessel. You see the lumen profile. This is the most expensive angiogram you can get. It's got all the information we need. We're going to be doing a MLD max guided approach, morphology, length, diameter. What we're going to do is, this is our lesion of interest. As you can see on the co-registration, what we're going to do is scroll into the lesion, and already what you're going to be able to see is some interesting features, and that is you see a very smooth pattern on this wall. This is debulking caused by rotablation. And what we're going to go now is go distally to an area of the artery that's large on our multiplanar reconstruction and make a vessel measurement. We're going to go EL to EL. It measures 3.30. We're going to round down so we know we can use a 3.0 NC or a 3.25 NC for our distal stent as well as for lesion preparation. We're going to go and do the same thing proximally. Here's a lesion. We're going to come proximally, try to find a landing zone. You see at the bottom we have a measurement tool. 33, we have a 33 millimeter stent, we have a 32 millimeter stent, and we have a 38 millimeter stent. All are going to land into plaque. So we're going to end up using a 33 here. And we've got the lumen, and the lumen is telling us that the max lumen is 3.43. We can go up half a balloon size, so we can do a proximal pot with 3.75. So we need a 33 millimeter stent, but the most important part here is lesion modification. Here what you can see is the rotablator has cut into the calcium and debulked, and as we move through, you'll see some areas where the rotablator was insufficient. This is the maximum calcified segment. This is how you decide what you need to do next. When you see the minimal calcium thickness is less than 0.5 millimeter, it's a very reasonable approach to use an NC balloon size to your distal reference to fracture that calcium. And if I was in Vegas, I'm going to bet it's going to crack right here. We go ahead and do the same thing as we scroll back. We see lots of calcification. We see one calcium fracture. That calcium fracture happened at an area of very, very thin calcium. We have other areas of calcification more proximally that are thicker. We may end up needing to do a rotoshock, but our next step is going to be to do an NC balloon.
You know, this is great. We don't have to think. We just say, Ziad, what are we doing next?
Yeah, Dave and Herms, I think that this actually dovetails nicely with Jazz's initial lecture that takes out
Right.
the indecision. You know, whether it's trying to determine whether a series of atherosclerotic plaques are hemodynamically significant or taking a look at their histopathology and deciding what's appropriate for a strategy and what's the length and diameter that you need to use.
Listen, for everybody in the audience, this meeting is about doing the right thing for our patients, and if we're not doing this kind of imaging, I know that we have the world's expert on OCT and IVUS and imaging, but this can be done in your own labs. We need, as a profession, to get to this point where we're interrogating the vessels like this. I think the only thing we should be dogmatic on is that we need to do a better job at imaging these so that we get hopefully better results.
Yeah.
Herms, why don't we dilate this live? And then we're going to shoot to the other. Ziad, you want to talk through? Ziad, why don't you come over here so you
Yeah,
can
sure.
see? You can talk through what Herms and I are
So,
doing.
David,
as we mentioned-
as you're working, just for the audience, just for teaching points, Herms, you got a 7 French guide in here, is that right?
7 French. We have a 7 French guide extender. After we got the roto, we switched out the roto wire for a wiggle wire just to not have any issues. And now this is a 3.0 NC.
Great teaching points, yep.
I had a question for the operators in the panel.
What do you think, Frank? Just a
with a long
nail
calcified
it.
segment like this, any relative advantage of orbital atherectomy over roto here, just in terms of the uses of the
12?
calcium and
Oh, how you want
how
me to
you
go?
can potentially
Keep
fracture it
going.
better?
I ain't
Yeah,
busted.
so the question gets around when do you use orbital, when do you want to use rotablader? I think when you get high-grade stenoses that you need a front cutter and
16.
you want to drill, this is what you use. If you've got a long calcified segment that you can get, that you don't need that same sort of front cutting, then you can do the whole thing with orbital. Lots of overlap between the two. Some of it's just
Yeah.
individual preference. All produce the same sort of pre-dilatations and stuff that you want, the fractures that you want. This synergism of atherectomy with
There you go.
shockwave
All
has
right,
been
store floor on that.
extremely helpful
Let's
for
take a picture,
most
make
of our
sure we
cases.
didn't do anything interesting.
Yeah, and getting
Laura?
back to your point, there was a high-grade stenosis in your question of the rotabur. I think
Beautiful.
everyone on the
All right.
panel was in
Beauty.
agreement that a 1.5 burr was the right way to start. That's how we mostly
Let me just
usually
get
start with
this up
our burrs. And
that
if you're
back
not
a little bit.
crossing, just go up on the RPMs. You can go as high
me
as
pop
210,
that
220
in. A
and
little puff, just a little
and
puff.
cross that way. I think sometimes
Yeah, that's got it.
folks
Sorry
get a
about that.
little
Let me do that again.
nervous
I
going
apologize.
that high.
I have a very, very low threshold for going up. Everybody's been
There we
taught
go.
at 160. I violate that continuously, 180, sometimes 200. The whole point is to try to get through safely, efficiently, not get
pretty
trapped,
good.
and not produce too much of a slurry of atherosclerotic to bleed
Way out
downstream.
John,
And-
you taught me rotoblader. What do you think? What do you think about what we're seeing here with our balloon dilations?
Yeah, tell us what you're using, Dave.
3.0 NC, and the distal, as you saw, go back a picture. The distal did not want to yield. Go back. Run that and see if that's it. Yeah, this is the picture. The distal did not want to yield, and we just gave it a little more love. We went to 12, we went to 16, we went to 20. Right there, it hasn't given yet. And one thing that I do believe in personally is once it yields, don't keep pushing on it. Make sure that you haven't created a perforation or anything else in the vessel, which is rare, but it does happen.
So this is kind of a poor man's test of compliance, right?
Absolutely.
So
Absolutely.
if you can do it with an NC, that's nice, and you get that data somewhat from your OCT. If you have areas that are resistant like this, then this is a classic indication for shockwave on top of that.
There it
Keeping
is.
in mind that
Boom.
that's the equivalent of 50 atmospheres, but your balloon's only up to 4 to 6 atmospheres, so the chance for perforation is significantly reduced. It's not like
good enough.
jacking up this NC balloon up to a very high pressure and risking a perforation.
Okay.
Also, knowing that the calcium was less than 0.5 in thickness, you could also consider taking a cutting or a sculpting balloon, not with the goal to expand, but just to crack some of that thin cap calcium, and then follow it with an NC balloon where you might have an easier time
Okay, what
expanding.
we're going to do right now
Excellent point.
is we are
Excellent point,
going to throw next door, and we're going to re-huddle and decide what our next step is. So we have Bob Riley, the good Bob Riley. We have Alok Sharma and Bimal Padalia next door. Why don't we throw to them?
Okay. Oh, that's why. So also.
Guys, can you hear us?
Oh, hi. Good morning, guys.
Good
Sorry,
morning.
we have been working here. Let me first introduce the room here. To my left is a good friend, Dr. Robert Riley from Bellevue, Seattle, who needs no introduction. He's a chip CTO operator. I have another good friend, Dr. Padalia, who's the imaging guru and will tell us what to do with the stenting and post-dilatation. To my right is Brittany, who has done this multiple times with the live cases.
This is 100 per.
On the X-ray, we have Robin, and circulating is Bailey. We do have anesthesia colleague here too, Dr. Lopez, who is helping us with sedation. So we're going to go ahead with the case presentation right now. So this is a 70-year-old male who presented with exertional angina, class 3. He has a history of hypertension, hyperlipidemia, chronic kidney disease. So he saw his primary cardiologist, and they did a CT coronary angiogram, which showed a calcium score which was 1,650, with a mixed calcified and fibrotic plaque in all of his vessels. There was also left main moderate to severe stenosis, along with severe stenosis in all the vessels. So he was put on some appropriate medical therapy and underwent a coronary angiogram. Next slide, please. So as you can see, this is the right coronary artery. So there's a focal lesion in the mid-right with some moderate disease in the proximal to mid with some calcification. Next slide, please. And if you look at the left system, there's severe stenosis at the ostial circumflex, maybe some plaque in the distal left main. So proximal right is proximal LAD is little aneurysmal with severe stenosis, and there's an OM branch which has severe stenosis as well. Next slide, please. If you look in the cranial views, you can see there is some stenosis of the distal left main, and again, stenosis of the proximal LAD. And you can see in this iliocordal view that there is severe OM1 disease as well. Next slide. So if you calculate his syntax score, it came out to about 39, and the syntax 2 score showed a PCI mortality at 12% and a cabbage mortality at about 11%. Next slide. So appropriately, I think the heart team at Honor Health here sent him for coronary artery bypass grafting because he's a non-diabetic with multivessel disease, left main disease, and a high syntax score. But I was told that patient turned down a bypass and wanted stents instead. So I think I'll stop here and see what the panel thinks, and then I'll hand it to Dr. Riley to tell us what we have done so far.
Okay, let's have our panel chip in.
Yeah, I mean, it's a great case. You know, the tricky part of your case is obviously, you know, the distal left main and actually the ostial circ or the proximal circ. You can see it was pretty calcified, and I think all of us, we've done a lot of left main work, remember that that's the spot that we always have the most problems with stent expansion and, you know, recurrent ISR, so it'll be interesting to see how you want to approach it, but it's definitely a complex case.
Benita, what do you think?
Yeah, I mean, because at least on the angiogram, it looked like there was some calcium, and for all the comments that you've already said without repeating you, I would probably consider, you know, taking the RCA off the table first, and just to provide a little bit more room if, in case the left main LAD circ gets complicated. So I'd probably do the RCA first, and then move on to the left main circ. I'd also want to know what the patient's hemodynamics are like starting out, you know, what he's like clinically.
Anybody else?
I think the first thing is that this person underwent kind of an appropriate heart team type of evaluation, and certainly be great to hear about some of the details with the surgical evaluation and the discussion with the patient. But assuming that, you know, there was a good coherent discussion and a value-based decision, this is certainly completely indicated for revascularization. think the upfront conversations are about, as Benita mentioned, right heart catheterization. I think I would be interested in the aortoiliac system to make sure if I needed mechanical support, which is certainly a gray area, I'd love to discuss on the panel about whether or not that needs to come up front. And then I think the extent of revascularization, how much to do at this one step. The left main is probably the most prognostically important, and so that might be the side to start with versus, again, providing, as Dr. Shah said, insurance with the right coronary. If that were to have a complication, though, then that might also be a difficult situation. So it'd be great to hear how the panel thinks about which order to go in and our operators as well.
Yeah, so all great questions. Keep going, guys. We don't want to hold you up. Let's see what you did.
All right.
I think really the question gets around mechanical support and then what it is you're going to do first versus second and what the techniques are going to be.
Yeah, I think those are great questions. So we did do a right heart cath, and he had some mild pulmonary hypertension. His PA pressures were like mean PA of 27. His RA pressure was about 9, and wedge was okay. His blood pressure is fine. His left ventricular ejection fraction on the echo was about 45%. So we debated about hemodynamic support as well. And because we are going to do a complete revascularization in one setting, we thought maybe it's appropriate to do hemodynamic support. Bob, you want to chip in?
Sure. Yeah, always happy to chip in. So we have a gentleman with a high syntax score, as discussed. Heart team discussion. Patient was given the appropriate pros and cons of percutaneous versus surgical revascularization. Chose percutaneous, and so we were asked to provide revascularization. Now, one of the challenges is because of logistics, having to do it all at one time is sort of where we're at now. One could argue, certainly, as Dr. Shah mentioned earlier, doing the RCA and this is stage procedure and coming back for the left main, although to Dr. Jaffer's point, if you have an issue, then you've done the non-prognostically important vessel first and then had an issue and really not necessarily provided benefit and having to move to an urgent or emergent surgery, which certainly has its own issues compared to elective procedures. So we decided to do the left main first. Again, very interesting discussion. No right answer there, but I love the thought there. We also want to just thank everybody that's here before we get too deep into it. We've got our Boston Scientific team, our Shockwave team. We've got our Abiomed team. We've got Bailey, Sirkin, Robin, X-Ray, Brittany Scrubbin, and Dr. Lopez on the anesthesia 1s and 2s. So we really appreciate everybody being here. Team sport, as everybody knows. So Dr. Sharma was here, did the right heart cath. We saw what we saw, relatively euvolemic, mildly high right-sided pressures, relatively left-sided euvolemic. Our index, cardiac index.
I think it was normal.
3.2. All right, so power calculation based on the map looks good. Yeah. So we moved on. We took our setup shots. What we did was we put an Impella in, camera, if you want to show here, what we did was a single access. I think this is becoming relatively standard. I don't know if this is super novel, but Impella through the Impella sheath micropuncture kit. Exchange out for a J-wire, a 7 French 45 centimeter sheath through that, making sure it's the hydrophilic one. In order to be able to get it as far as you can. There is a transition from hydrophilic to hydrophobic, so you can't get it all the way in, but as long as you're using a 100 centimeter guide, you are good to go. Although if you do CTO PCI with this, one has to remember you can only use 100 centimeter guides through this. So we then started our setup shots. As you can see here, an AP caudal, my favorite. You can see there's a little bit of OM1 disease. Obviously a nice tight fun zone there in the ostial circ. Left main is intriguing. You can see that distal left main. A little bit better here. You can see there's a knuckle curl aneurysm right there at the bifurcation, indicating that there's likely significant disease just proximal to it in that distal left main, calcified. And then the LAD is just a nice rat's mess, right? Bunch of calcium all the way down, super tight. We always take a cranial shot, right, to know where our distal landing zone is in our LAD. Looks like there's calcium all the way down. We look like we may angiographically have normal vessel just proximal to the second diag. Rest LAD looks reasonable. So what we did is we wanted to image first, right? We wanted to know multiple things about that. We wanted to know, could we get our imaging catheter down? Because that will give us prognostic significance as whether we need to use atherectomy versus something else. So we did a little balloon inflation with a 2.0 to carry balloon by Terumo, lowest crossing balloon profiles on there, 1.5 and 2.0. Got across very easily. We've got workhorse wires down both. Then we did imaging. We imaged the circumflex and the LAD, and I'm going to let my good friend Bimmel talk us through the imaging. Bimmel?
Yes. So this type of case, if you're going
What's
to
up?
offer them percutaneous therapy,
just get going?
cannot do it without intracoronary imaging. And basically, the thought process going forward, first, based on this anatomy, you're interested to know what does the ostium of the left circ look like. So I'm showcasing here a distal proximal pullback of the proximal circ into the left main. And as we kind of move forward here, you'll see the ostium of the circ, and I'll stop it there. The ostium of the circ does seem to be diseased as calcium that then extends into the left main. So you got significant disease in the circumflex as well as extension of that disease in calcium into the left main. If you're looking at your distal reference segment here, you don't have an area of normal. You can see the media very well with IVUS. You can see calcium here, but the fact that you could see some of the adventitious reverberations behind it tells you this area of calcium is likely not very thick. And so your distal reference in the circumflex is about 3.5. Next, we move to the LAD. So left circumflex doesn't look like it would need atherectomy. Once you, now we will image the LAD, again going distal to proximal. If you look at the very kind of distal aspect of the area that we want to stent, the reference there is about 3.2 media to media. So you're going to size your stent to the nearest stent down, which would be a 3.0. As we're going forward, you'll notice that there's areas of calcium that appear not to be thick because you can see reverberations around it. And there are areas in the proximal LAD that have 360 degrees of calcium and with very high attenuation, you can't see around it. So concerning in terms of being able to expand that area and needing either pulse therapy or atherectomy in those areas. So based on this information, the LAD appears like needs further work in terms of prepping the vessel, left circumflex less so. There's disease in the ostium, so an upfront two-stent strategy should be considered.
So
what do you do, Rob?
I don't want to beat the proverbial dead horse here, but this is another excellent example of how indecisive, unclear areas on your angiogram have been perfectly elucidated. When you have a aneurysm like that, you can see what the stenosis is, you can see what it's composed of. You've already made several decisions as to what you're going to intervene with, whether you need an atherectomy, whether you need shockwave, whether you need anything else to be adjunctive other than just balloon angioplasty, and you've got complete clarification.
And then you mentioned this patient has CKD, so using an automated pullback to get all of your length measurements and all of that can save you contrast as well. I don't know how low the GFR is, but...
So the GFR was like 52 or 54. And we have only used minimal contrast. I think we have only used about 30 or 40 cc of contrast so far, and that's the advantage of IVUS-guided PCI. We really don't need to give contrast. Now, I'll be curious to see what the panel think about stenting strategy here. Would you do any atherectomy or vessel prep, and like what stenting strategy would they choose? And then Dr. Riley will show us what we did.
Yeah, so great questions. Again, as Dr. LaSala pointed out, you've got a left main, what seems to be a 111 Medina classification with calcium and the Prox LED. And so, Rob, tell us how you're going to vessel prep and what are you thinking about with two-stent technique and how are you going to take care of the rest of this case?
So Bemel already told us what we need to know. I'm just here to reiterate. So what we saw in the circumflex, interesting, I will say, I've done a decent number of left mains. I don't know, not as many as some people, but more than others. And typically that ostial circ is where you see that sort of nodular, eccentric calcium, and that's where we get a lot of stent failures because of that. And I think that's why bifurcation left main stenting typically loses, right? In the most contemporary data, oftentimes to conduit grafts. But in this case, we were actually pretty lucky in some respects. The circ really didn't have a ton of calcium.
That's right.
It was really confined to the distal left main and into the LAD, and so in some respects, that actually is pretty great for us,
Right.
And more so for the patient. So that doesn't really need a lot of preparation outside of just a semi-compliant balloon. We also made the decision as a group, looking at that OM bifurcation, what do we really want to achieve here? So for example, when we're on an Impella, it doesn't mean that you can just do whatever you want with no ramifications, right? We want to be efficient, we want to be safe, and we want to get the patient what they need. And so if we do a residual syntax score for a single OM, it's really not that high, right? And it's not prognostically significant. So we decided instead of doing a bifurcation stenting strategy of the OM and then doing a bifurcation of the left main, we were going to concern ourselves with the prox circumflex as we saw in imaging back in the left main and the LAD. So, and again, we can certainly talk about that, but I think it's not an unreasonable strategy. So then what we did was we looked at the LAD and we said, gosh, that's a lot of circumferential thick calcium. But as we go here to this cranial shot, what we see just proximal to that second diagonal, there's disease there, right? We want to probably stent to that second diag, but that's relatively soft plaque. So we don't have to do anything other than typical semi-compliant balloons, right? What we need, see that aneurysm right at the first diag? What we need is to do calcium modification there. And what we know is that we got our IVUS down. That means we can probably get a shockwave balloon down. And we know that that's going to be more efficient necessarily than drilling. It's going to give us better, not just superficial, but deep calcium modification. So why wouldn't we do that? So that's what we did. We got a 1-to-1 size 3.5 shockwave balloon for that prox LAD, delivered 50 pulses there, and then delivered another, come on now, delivered another right there at that bifurcation where we know it's a 4.0, but we just wanted to make sure that we can get our 4.0 in. We then took a 4.0 in to that left main, just hung it just into the prox LAD, delivered all 80 pulses throughout the left main. Let me just show you, that's the shockwave balloon. Good expansion. I will tell you, there was no flow once that shockwave balloon went in, so we were very happy to have our device there. We did get good, the lesion popped right in the first 10 pulses there, but we went ahead, because again, remember, you have to overlap the balloon half a length because your emitters are diametrically opposed. You want to make sure you get all your therapy done there. So we kind of went back and forth along that lesion. As you can see here, that's delivering the last into that left main. Then we did our 4.0 shockwave balloon here. There you go, all throughout the left main. We've got our 3.5 semi-compliant balloon, 1-to-1 sized here for the circumflex. Imaged again. And Dylan, do you want to take us through that repeat imaging after our calcium modification?
Absolutely. So right before, in terms of sizing the balloon 1-to-1, we knew where the concentric calcium was, and we looked at a reference segment just distal to it. And media to media is about 3.9, 4.0, so we downsized to 3.5 to get 1-to-1. And after the shockwave therapy that Rob mentioned, let me play this. You will see areas that were, let's flush through there. And let's play that area of high calcium, and let me stop right there.
Those are some really good learning
points. You can see in those areas, you can see dissections of the calcium where the pulse therapy has cracked that calcium in the prox LAD.
Do you guys see those cool fracture points? It is rad. I mean, it is awesome. I don't know why I thought awesome was more professional than rad.
Yeah, we love those fracture points.
Sorry.
Right here, right here.
So guys, we've got just about 25, 26 minutes left, so we want to make sure we can cover this whole case.
Yes, sir. All right.
Rob, you're speaking at the speed of light, so we just need to have you give us a little bit more clarification sometime, but we don't want to miss anything important that you're bringing up.
Sorry, we just had a lot of work to do trying to give everybody their due. All right, so now we've prepped our vessel, right? We've proven that we've had vessel preparation via intravascular imaging. We've done our circumflex there. So now what we decided to do, as was discussed at DK Mini Crush, just based on data and based on the angle, Culottes great. It's just this is a really broad angle of the circumflex, so we decided to do a DK Mini Crush. Oops. So what we did is we've got our stents, hung it out just a little bit, deployed, post-dilated with a 1-to-1 sized NC balloon, a 3.5 in this case. Now we're getting ready to take a picture and crush and then move on. But I'd love to have the panel sort of do some discussion while we get our work on.
So this is a 3.5 by 12 stent.
You ready?
Yeah.
Yeah, so let's take a little time while you're working. This is great, Rob. Thank you. And a look, bifurcation strategy here. So,
Go ahead.
Benita, how would you do this back at NYU in Bellevue?
Yeah, I mean, I think this setup is a good setup for DK Crush, so I probably would have just done the same DK Crush strategy here.
Yeah, I mean, I think DK Crush is fine. I think, before I was doing DK Crush, I probably would have done team protrusion, but like I would have made the main stent go across from the left main into the circ and made the LED the daughter branch. But now that I've done,
Shall we
I have more experience with DK Crush. I'm more comfortable
Can I
with
get
it.
that other sham blue, please?
Farouk, what do you think?
I think the
What's your strategy of choice here
angle is
for
good
this
for
angulation?
a DK Crush in this situation. I think if it were narrow, of course, I'd consider
Can I get a
Kulot,
new
but
2.0 to carry you
things are
balloon,
well
please?
prepped. There was clearly significant disease at the ostium. In terms of, there was an important trial from EHJ earlier this year about left main and provisional stenting, and I think historically, of course, we know the DK Crush 5 trial showed superiority compared to provisional, but that was revisited in the EBC main. In this case, given how much lesion preparation was done and the potential for dissection after an NC balloon, I think it's certainly very reasonable to cover it. It'd be interesting to note, because it was not particularly long, this osteal circumflex lesion, would anyone consider that to be provisional at this point?
Dr. Singh is a member of the European Bifurcation Club. What would they do over in Europe?
I'd love to hear that.
Well, I'll tell you, I'll do my own technique that I developed and that we are in the process of publishing, which is actually DK Crush, but 3 steps less, and which is very, very similar. You put a, everything is decided on imaging. So these guys are doing an amazing job. Everything is decided on imaging. And when we do is you image the ostium of the circumflex and mark the ostium exactly where it is. So what we do is we put a stent in the ostium of the circumflex, leave the stent balloon, rather than crossing and doing, again, DK Crush moves, you leave the stent balloon in there. And then you deploy your left main to LED stent, okay? And when you deploy that, you are pushing the stent where it needs to go. So when we looked at models, you actually are causing longitudinal deformation and crushing it axially also. So when you do that, you're actually pushing it where it's supposed to go, but you're deforming it. So your stent balloon is still in there. It's jailed behind the stent. So when you deployed it, deploy the stent LED thing at high pressure, no problem. Then what you do is you correct the deformation you just did with that balloon in here, but you're deforming the left main balloon, the stent already, no problem.
I'll take
Your
that
stent balloon is there. Take it out.
It's only 1.5. They don't have to.
After you've done the side branch, take that out,
What do you want to
reinflate it,
2 3/0s?
and then proximally optimize,
3.5?
and you have better
2
than
3/0s.
DK Crush.
Can we get
I have
2
models
3/0,
and stuff
15
is
NC
better than
balloons,
DK Crush. So
Yeah.
I think it's similar to
2
that,
3/0s.
and I think proximal optimization and whatever it is very, very important. And then like I talked about yesterday, then doing kissing balloon inflation with short overlap, not large, do not create bottleneck.
Just kidding. Hold on.
Short, low pressure inflation, high pressure sequential, low pressure kiss. Or pot, side, and repot. And
Although,
so
Jazz,
this
I'm
is
very
exactly
upset.
what it is. And that's what I think the European Bifurcation Club has gone through, like Farouk was saying. So it's changing, but those are actually very, very important things we never used to think about.
Jazz,
So-
I'm very upset
yeah,
because the
so-
first time you told me about this bifurcation technique, I thought it was awesome, and you kept telling me you were going to publish it, and I kept waiting. I'm still waiting. I need to see it. I want to see it. I think we all want to
My
see it.
fellows are a
friend.
little lazy, that's the problem. so we got to get going here.
Well, would love to see it, my man. I think it's very cool the way you describe it, and it's pretty elegant. So I think we'd all love to see more of that.
So you've chosen DK Crush. Rob, talk a little bit about the recrossing of
Go
the
ahead and go
wire.
through
We were
14.
watching you work. What are the types of things that you need to think about, where you want to cross
16.
in the standard DK Crush?
Down. All right. Okay, cool. So what we've done in our standard, because we want to get to the kissing part now, potted a little bit with our stent deployment balloon. Now we want to kiss. So people can do it however they want. I end up keeping my jailed wire in, just using it as a marker, and then taking a second wire in, crossing through. And what we want to try and do is cross on the distal side there, just so we can get good apposition of the carina and shift it appropriately. So we sort of went down the LED and drug back and were able to switch in. You saw me have a little bit of a struggle, which I'm sure Bill will give me a hard time for later, as he should. And I had to take the guide back and get the angle towards the cert because it was just biasing because it's a Xi'an blue and it deforms a little bit more readily than something like a
and
run
that's
through.
typically what does happen. Absolutely right.
Yeah.
And
So you saw me just shift the guide up just so I could get a better angle. So crossed over. I will say, you know, over the years, and I'm sure everybody has different experiences, but I rarely can actually, once I wire through, get the appropriate sized NC balloon through without doing some modification of the stent struts. And so what I've taken to doing is using Takariu balloons, again, these low crossing profile balloons. We used a 1.5 in this scenario up to high pressure, just to get us room.
That's exactly what I do now, Rob. I agree with you 100%. It's no use wasting time taking your NC back through at the size you want to finish up with.
Yeah.
Just take out the 1.5 and we use the same thing. The Takira balloon's been great
Take the
going
other
across.
NC, please.
There's a couple of little tricks you can use in addition to that. We'll see how you do with yours.
And now listen, balloon size is the kiss. Everybody's got opinions. Very few people have data. So we're going to use 230 NC's balloons here if everybody's okay with that. Is that okay with everybody on the panel?
sounds good.
Sounds good. All right, fair enough. Sounds good. Then let's move on. All right, fair enough. I think we're going to stick with this. You good? All right, perfect. So here's a question that I'd love to hear people's thoughts on. We just did the shockwave, and we imaged and we showed fractures. Do we need to do anything else to this vessel, or can we just put our stents in? I'd love to hear people's thoughts on that. And just so you know, there's no right answer because there's no data.
No, you guys imaged and you had fractures and you had good luminal gain. I don't think you need to do anything. You just put your stent in, you're good to go.
Cool. We
But a lot of
appreciate that.
times, even shockwave, there is a little waste, and you've used all your
I'd like to go up
shocks.
first.
What you do is you take a non-compliant balloon and crack it, and usually
I go up
cracks
to
very
12.
well. You don't be disappointed about
want you
that.
to go up to
But here, I think you guys cracked it pretty good, so I think stenting is probably the way to go.
Thank you so much. We appreciate that, Dan.
And that's why the recommendation really is to go 1-to-1 with your IVL balloon
both gonna go up
up
to
front.
8.
Don't undersize that. Just go 1-to-1. You can
Perfect.
see whether it's fully inflating
down.
also.
Yeah,
perfect.
with a good lumen after shockwave, there's no need to post-dilate it. Save it till after the stent goes in.
Awesome. I appreciate that, everybody. So, oh yeah. Yeah, so we're gonna toss it back to the other room, who's gonna show you some fantastic stuff, and we'll keep working, and we'll see you all back in a minute.
Nice work, guys. That's
there.
great.
And we
Dave,
got-
what do you got?
Show the floor. So, 2.5, off floor a minute,
Yeah.
and go to the video. 2.5, yeah,
There you go.
2.5 stent more distally, followed by a 2.5 NC, 3.5, and that's all based on OCT. And 3.5 Zions, 2.5 Zions distally, 3.5 prox, 2.5 Trek NC, 3.5 Trek NC proximal. This is what the final angiographic result is. More importantly, Ziad, show us the final OCT result. I mean, this angiographically looks gorgeous, but I care really what OCT looks like.
Thank you. So MLD max, so medial dissection, we look at the distal reference, no medial dissection at all. We jump across to the proximal reference, no proximal dissection. We look at apposition. The red bar shows us there's some very minor areas of malapposition. That's not not expected because of the calcium fractures. Our expansion is 90%. We are done. The only thing I want to show you guys is as we scroll through where the fractures are under the stent so you can see what it looks like when a fracture is stented. Now these actually typically heal with fibrous intimal hyperplasia. They don't get recalcified. Here's another big gap. You see that? And actually, if we just go back for 1 second, remember we predicted that the calcium was going to fracture at the segment of 0.40. And I just want to show you guys that's what happened. And so you can see if you use this strategy, what you can end up doing is getting all the fractures that you expected. This is the exact segment where we were measuring at 0.40. There's a fracture exactly at that position. And you can see that this lesion is very adequately prepared with multiple fractures throughout, making sure that we're going to get the type of expansion that we did on our final.
Okay, so go to the final angiogram. and taking all this into account, I mean, Herms, the term we use with OCT is precision PCI. Does this get any more precise?
No, I'm just sort of blown away
I know
with
it.
the, predictability. And there's no guesswork. There's no sort of art to this. This is, you have the data, and the imaging shows you what to do.
So can you work from home? Look at the OCT images from home. We'll just send them to you.
It's a virtual world, man.
Herms is just going to stay here for another month, and we're going to catch up on all the cases we're behind. I mean, this is precise. I just love OCT for this reason. It's very precise, and this isn't going anywhere. I mean, obviously she's in her mid-80s, but this isn't going anywhere, right? The chance of this closing is not high in a non-diabetic. Okay, one other thing. Herms, Protego, where am I at?
Zeros and 0.1.
All right, so I got a 0.1.
And that's because we were singing stuff that we normally
We were
don't
singing stuff that we wouldn't ordinarily do. But here's the point. Everyone on this side of the room got essentially no radiation. We could do, Ziad, 1,000 of these with little, if any, radiation exposure. Herms is going to be the next president of Sky?
In a couple of years.
Yeah, and he's already said after experiencing this, and this has always been an important concept to him, that Sky needs to lead the way in radiation reduction, right?
Right, and out of the lead. I think it's not just radiation, it's get out of the lead.
Agreed.
Save your spine.
All right.
Guys, one quick question. I want to tie this into Dean Kariakis' lecture about shortening the depth utilization. Beautiful angiographic result, OCT optimization. What are you going to do for post-procedural dual antiplatelet therapy?
Well, I think with this, if she were a high bleeding risk patient, if she were an HBR, I would have no truck with 30 days of dual therapy followed by monotherapy, not with this kind of result. Now, the only caveat, this is a longer lesion than we use in many of the trials for 30 days and then monotherapy. But if we had to come off depth for a procedure or whatnot, I would feel very comfortable doing that.
Yeah,
Ziad?
absolutely.
Yeah, I couldn't agree more. This is you have full apposition, you have no edge dissections, and you have full expansion. This is as safe as it gets.
And a non-diabetic.
Yeah.
The other thing that's important, Ziad brought it up, is you have malopose stents proximally, but don't chase them because data shows that it doesn't really affect anything. And then you will never be able to oppose them. You take a 5-0 balloon in there, you're going to perforate. So don't go after those, especially when they're eccentric and calcium. It is very, very important. So people do imaging and they say, well, these stents are malopposed. In calcium, they're eccentric. You will never oppose them. So don't go after those. That's the problem. You get into problems. So that was a very, very important point, and I think you guys did great.
So
Fantastic job, guys. We've got we're a little bit behind. We want to thank you for your outstanding work. Congratulations to you and the staff. A fantastic result. Thank you.
We're back.
Guys, we're back. We've got a few minutes left. Let us know how you've done. We've got to wrap it up.
Yeah, absolutely. So again, thanks for coming back. So we finished up with our circ. You can see the KISS with 2 3.0 NCs. So then we got to work on the LAD. You can see we pulled back just a little bit so as to not to gel that diag with a 3.024 drug-eluting stent as sized. We're going to pot the proximal aspect to a little bit more like a 3.5. So now we're taking, and we left just a little bit of room into the LAD because what we want is appropriately sized stent from the proximal LAD back into the left main so that we're not trying to create too much metal across the bifurcation there. So you can see there, then for overlapping stents, I just go up to higher pressure with my stent delivery balloon there. And so now we're getting ready to take, and then what we, I'm sure everybody does this, but I use my stent delivery balloon to try and size the next length. I always do my left mains, or frankly, my ostial left mains and my ostial RCAs based on the data that was in JAC, I want to say, it might have been 2 years ago. I feel like with the pandemic, I can't remember. But They did CTA over, actually, Farouk's up there. They did CTA overlay and found the best angles with which to actually find the ostia and things like that. And LA Crane for both was the best. And so I started shifting my practice to using LA Crane to really, sometimes that nose in the spider that we want to use, really you can't see it, and so you'll miss kind of that nose as it comes over the cusp there. And so here you can see we got our appropriately sized. We went down a few millimeters, and so now we've got a 4020. We are using a Megatron in this case, which is the sort of new Boston stent with thicker struts, better for osteal stenting in this case.
Yeah, so great teaching points on the LAO crane, getting both the inferior and superior roof of that osteal left main. Megatron's a great choice here for expansion and radial strength. And again, you've got the imaging to size, so this is coming along beautifully.
We really appreciate that. So now, what we'll do...
Yeah, just one misconception, too. The name Megatron does not mean the strut thickness is back in that old, first-generation thickness, okay? It's still equivalent to what you have out on the shelf, except for the real small ones like Synergy and Cyro.
Okay.
That looks great.
But it does have an increased radial strength.
I want to come back to
And the visibility is great. I mean, the visibility is great. We published paper on osteal lesions, right and in left mains with imaging, and we actually either do co-registration or we mark the ostium depending on what it is, and we place it exactly depending on whatever view you want to go to, just mark the ostium, do it on imaging, and you can nail it pretty much perfectly most of the time, like you guys are doing. So imaging is very, very essential in osteal lesions.
Actually, hit AP crane, please.
And I appreciate Rob's comment about really planning his LAD into the left main, since he had realized he was going to need 2 stents to keep that overlap further down and not to have so much metal at the bifurcation. I just wanted to highlight that point that he did make, because you have all the information on imaging. You should you would be able to